All right, well, it's 12:30, I think, on a Saturday afternoon. Let's just get going and let everyone else enjoy the rest of their Saturdays. Hello and welcome to the session titled Mistakes I Made as a New Grad Physical Therapist, presented by Dr. Russell Linville. My name is Cole Birch. I'm a student physical therapist at Concordia St. Paul. I'm the moderator for the session, and I will help with the relaying of the questions to the speaker. Unless you have a different way you want to do this, we would like to just hold off the questions until the end of the session, at which point you can raise your hand or type in the chat. I'll call on the hands in the order of which they appear. So now I'd like to introduce Dr. Linville. So a little bit about him. He is residency trained. He's a residency trained physical therapist, dual credentialed in both orthopedic and sports physical therapy. He currently practices full-time at the Training House and Twin Cities Orthopedics here in the Twin Cities, treating a bunch of different athletic injuries in all ages. Dr. Linville takes special interest in working with overhead athletes, as well as complex shoulder and elbow patients. Outside of the clinic, Dr. Linville is an adjunct faculty member at Franklin Pierce University in Arizona in their emerging hybrid TTP program. His experience includes working with youth, amateur, Olympic and Paralympic, and as well as professional athletes. So with that, Dr. Linville, take the floor.
Cole, thank you so much, and also thank you, Minnesota APTA, for inviting me to do this. This is a great honor. And I remember almost a decade ago, I was in your shoes. So the tables have turned. It's kind of funny how life works out. And with that, so I have a decade of experience of making mistakes, and especially those first couple years, there's a lot of things I would have done differently. So let's get through this. This presentation, we have until 1:45. However, I really doubt it's going to take that long. I made a lot of mistakes, but maybe not enough to fill up an hour and 40 minutes or whatever. So I hope we can fill some time with some questions as well. And as we get along and go along here, rather, we will. I'll tell you how you can contact me, and there's a lot of students that want to check out the facility I work at. We enjoy having students there. We take students for clinical rotations. It's a good way to get into in the sports PT world and network. So, and that's networking is one of the big things we'll talk about in terms of mistakes and not making mistakes. So, without further ado, let's get into it. So, the title of this presentation, as you can see clearly here, is Mistakes I Made as a New Grad PT: How You Can Avoid Them to Hit Your Target. So as we continue on here, this is what I look like. I don't know if you can actually see my picture, rather just my screen, but this is what I look like. And you can contact me on various forms of social media. So LinkedIn, Instagram, I have a good presence there. I like to update that quite often. Twitter, not used as much, but certainly could reach out to me there. I have a YouTube channel as well, which I share a lot of the Instagram stuff on. And then, of course, email. You can send me a private email if you'd like to as well, if you have questions, concerns, or want to try to set up something for shadowing, etc. So what's my background? Why can I give you this talk? So I grew up in Virginia. Some people in the Midwest say they can hear that little twang in my voice, but I don't hear it. But I always say it's you guys up north who have the weird, funny accent. So I was a collegiate athlete. I grew up in Richmond, Virginia. Played baseball at a D3 school, and then transferred to Virginia Commonwealth University. And some of you might know VCU when you guys. If we think back to 2011, they were in the Final Four. So if I'm aging myself here, I was in college then and undergrad then. So you guys were probably in middle school or something like that. So unfortunately, though, I sustained an ACL injury, and so this is a picture of me back in the day and how things have changed. Used to go with the shaved head look and was in the gym quite a bit. And so there I am, and that's the first exposure to physical therapy was having an injury myself. I always knew I wanted to get into strength conditioning, but never knew maybe physical therapy was a career path for me until I sustained my own injury. So with that experience, it really got me interested, much like some of you. So I decided to look into PT schools, and eventually and thankfully was accepted into Franklin Pierce University out in Phoenix, Arizona. So took a chance and went out west from the East Coast to the West, and really tried to make the most of it out there. This is a picture of, so Franklin Pierce, their mascot is the Ravens, and so they've created this cool mural there at the school, and it's one of the hallmarks of the school, I guess, in terms of taking pictures and graduation day and stuff. So I thought I'd throw that on there. So what's my current role? Well, I'm a sports PT at Training House. That's in Eagan, Minnesota, and there I serve as one of the sports residency mentors. And so we actually just wrapped up with interviews yesterday, and had quite the competitive amount of applicants. So 22 individuals applied. This will be our inaugural year having a residency. 22 individuals applied, and we have to whittle down to 2. So unfortunately, only 10% of the applicants will be accepted. All of them were very strong candidates, and so starting in July of this year, we start day 1 of our sports residency, and so I will be serving as one of the main mentors in this program. Before that, the past several years here at Training House, I've taken on students, and so I've seen, I think, 11 students in terms of clinical affiliations, clinical rotations here, and a lot of them have gone on to do things like residencies and things like that. So if there's an interest from the group listening here, certainly reach out to me, and I can try to give you a little more information about not only our program, but just residencies, fellowships, all those things in general. We'll touch on that stuff a little later as well. In terms of academia, so as Cole mentioned in the introduction, I am an adjunct faculty at my alma mater at Franklin Pierce, and there's a story within a story, but essentially they're changing the way they do it since COVID. They found that a hybrid program may be the most efficient way to have students from all over the country come in. And so essentially what's happening there, from my understanding, is that we're going to be doing online lectures, and then once a quarter they'll fly me out and I'll do labs out there for a long weekend. And so we've already been testing it this year. It seems to be working out great. So besides that, rather, I do some guest lecturing both at Concordia St. Paul and St. Kate. So some of you on this call I may have taught you at one point in time. And so hopefully that role grows as well. And it's really an honor to be able to help you guys and share some of the information I've learned over the years, and hopefully today share some of the mistakes I've learned. So most of the people I talk to are interested where I work, and so the residency program we started takes place at 2 different locations. One is out in Twin Cities Orthopedics in Eden Prairie. You have 6 months there, and then you'll do 6 months with me at Training House. And so just to give you a little virtual tour here of what Training House is and has to offer, we have a 1-minute video here. All right, thanks for humoring me and sitting through that. So yeah, that's where I work. So it's a 22,000 square foot sports performance facility on the campus with the Minnesota Vikings, and so we have a lot of connection to them here. Our orthopedic group is right next door. So the wonderful thing about working here is that the physicians and surgeons and PAs and everyone is right next door as well. So there's a really great interdisciplinary component to the facility here. So if we move on, so what's the real reason I can give this lecture? Well, it's because I've made a lot of mistakes, and when I look back and reflect on it, it's a miracle. Something worse hasn't happened to me in my career. So as we get into it, this is what we're going to be going over today, a little table of contents. Try to set this up almost like reading a book. if you will. So part 1 is going to be the mistakes. We got 4 parts here. We'll talk about the Dunningkruger Effect. Part 2 here, or chapter 2 rather, is going to be your problem, not mine. Chapter 3 is that's not what I want to treat. In chapter 4, that's going to be wow, we have to fix your imbalances. We move on to part 2 of this book. That's going to be the hit your target. We're going to talk about chapter 5 is going to be the KISS principle. Chapter 6 is ego is the enemy. Chapter 7 is build the base, and chapter 8 is relation shaping. And I threw a little trademark there to be funny, but it's a word I kind of came up with in thinking about this presentation. And then finally, part 3 is the conclusion. So chapter 9 is doing the right thing, and chapter 10 is passing it on. And so hopefully, at this point in my career, I hope I'm at chapter 10, which is why I'm delivering this presentation, and maybe you're somewhere in the first 10 chapters trying to work your way through too, and hopefully this presentation can get you through these chapters quicker. You'll also see me pop up once in a while to give a little input. These little thought bubbles are going to be popping up once in a while of I wish someone would have told me that examples. So here we go. Part 1 of mistakes. So what's the Dunning-Kruger effect? Most of you guys have probably seen this actually. If you follow this, the y-axis is confidence and the x-axis is competence, or your level of education essentially. So as you can see here, starting off early in your career, the least amount of education or experience that you have seems like the most confident you are. And so what happens very quickly though is that you start to realize you don't know what you don't know, and then your confidence level starts to dip, and you can follow along in the red line there. Once you get a little down in your career, you start to think that you don't know anything. You're not very confident at all, and you actually have pretty average competence. However, your confidence level doesn't match that. As you start to practice more, you start to realize that you're gonna you do know what you're talking about. Your patients are responding well to you, and your confidence starts to rise again. And so what you don't see here is that along this line there's micro fluctuations as well. So you're gonna have good days, bad days. You're gonna have patient experiences that are going really well. You're gonna have ones that are going horrible. You're gonna have parents calling, emailing you with their athletes, or their kids rather, that why aren't they back playing yet? You're going to have athletic trainers maybe being upset at you or really happy with you. And so you're going to have to take things in stride. And one thing I've learned over my career is that time heals a lot of things, not just physically, but also in terms of relationships. And the fortunate thing is you can always try to build not only your level of confidence as well, but also your relationships. So this is another slide here. So again, confidence and knowledge in the field. And if we think about this, the first black dot is I know everything. I don't need your advice. I've got this. Then start to realize you don't know everything. So there are so many possible disasters that can happen, and I don't know how to deal with it because I'm not an expert yet. And finally hit rock bottom. I can't prepare for everything. This is just too much. I'm not good at PT. I'm not good with patients. Nobody's getting better. There are moments that you really think this, especially early in your career. And I always I say this, and part of it's joking, part of it's really not, is that if I could go back and apologize to every patient I saw in the first 2 years of practice, I think I would, because I just didn't know what I didn't know. And I always try to treat them with respect and modesty and dignity, but I know a lot of people didn't get better as fast as they could have because maybe I was too stern or demanding too much, or wasn't really looking internally at myself how I could get them better as well. So then you start getting a little more confident. This is more complicated than you might think, but you know what? I can start to handle this. And finally, I work on improving my preparations gradually and learn as much as I can as I go. And the good thing about this is that knowledge and growth will never end. This is a spectrum that's on infinity. So this will just continue to rise and go up. And the good thing is that you can start passing on your knowledge to others. So just know that early on in your career, you're going to have a little bit of modesty, and be humble, because there's a lot you don't know. And my mistake that I made was I came out of the gates way too hot. I was very confident, and maybe the actual instead of confidence is probably insecure, and I was trying to hide something, right? So maybe I wanted to be that expert clinician early in my career, so I would essentially fake it till you make it kind of deal. And I think my personality helped get me through some of that, but in some relationships, I really burned some bridges because of this as well. So you live and you learn, and I hope you don't make that same mistake. Chapter 2, it's your problem, not mine. You've probably thought about some of this stuff before, is I really don't care what people think of me. I just don't care. If you don't like me, that's not my problem. It's your problem. If you don't, if you don't think that what I have to say is worth your time, then I don't care. The other thing is, I don't care if you like me, because I like me, and I'm pretty damn amazing. And so if you have this motto, then you need to start rethinking some things. And if you have a problem with me, that's your problem, not mine. You know, we already mentioned that. But these are 3 things that early in my career, I really actually thought this. And you know, I came out of the gates super hot, as I mentioned earlier. I wanted to take over the world. I wanted to treat everyone. All of my patients were going to get better. You know, nobody was going to have any issues. And if you were going to get in my way, then that's your problem. And if you don't like how I do things, again, you know, in terms of coworkers, that's your problem. I unfortunately wasn't intuitive enough to really think about that. No one really talked to me about that early on. So what I want to do is make sure you don't make the same mistake. And it is really important what people think of you. Your reputation is basically all you've got. The PT world is extremely small, especially in the sports medicine realm. Everyone knows someone that knows someone, and you never know, you know, let's say you have a poor interaction with someone today. They're going to remember that experience with you, and then 2 years when some sort of opportunity arises, it comes down to you and someone else, and they'll go, yeah, but you know what, I met that guy at a conference a couple of years ago. He's a real jerk. And you don't want to be that guy. You want to be the guy that they remember for all the positive and right reasons. So I really, if you're this way, if you have, and we'll talk about ego a little later, but if you have a little bit of an ego, certainly like I did, probably need to really self-reflect and analyze that. And maybe your mission is to flip all of these. Is I actually really care what people think of me. And if you have a problem with me, that's not your problem. I'm going to take ownership. That's my problem that you have an issue with me. And let's talk about it. Let's communicate. Let's figure it out, because I want to make sure that we're on solid ground. Chapter 3. That's not what I want to treat. So this is a picture of someone who just checked their schedule on electronic medical records, and they're checking out, they're seeing, you know, I really want to treat athletes, you know, for example. That's the world I work in. Who is this 62-year-old that just popped up on my schedule? I don't want to treat anyone over the age of whatever. I don't want to treat, you know, this certain diagnosis. This is not what I want to treat. And so sometimes you look at your computer and you'll do this. I've certainly wanted to do that before, mainly from documentation purposes, not patient interactions, but I still thought it was a funny video to throw in there. So what I want to get at with that's not what I want to treat is that you're going to have a lot of patients who on the surface looks like you have nothing in common. You don't like their diagnosis. You don't want to treat it. You think that maybe if we look into a little more into this, it's kind of a Mr. Jekyll and Dr. Hyde. Dr. Jekyll, Mr. Hyde? Yeah, one of those two. You got to take a look in the mirror and battle your inner demons about this, because this is certainly not anyone else's fault but your own. So why don't you want to treat this person? You need to take a look in the mirror. Is it because you have implicit biases that you don't even really realize? You might need to have some self-reflection there and see where your biases lie. Is it insecurity in your own skills? Never worked with a a certain group or population before, a certain diagnosis, you're insecure in your ability to treat it. Is that why that you don't want to treat that person? Or is this below me? I really only want to treat post-op knees and ACLs, and that's where my interest is. And if I get another person with just anterior knee pain, I can't do it. It's just so boring. I hate working with those people. These are thoughts I had in my career at one point, and I'm glad times have changed. But there are some people I thought, I'm better than their diagnosis, which is just totally backwards. And then finally, I'm only seeing this because at my practice, I'm the junior PT, and those other PTs, they've already established all the things they want to see, so I get all the scraps. I get the patients that come late. I get the patients that can only be seen at 6 p.m. and I want to go home. I get the patients that, send too many emails and badger me outside of work. I get, et cetera, et cetera, et cetera. And so really all of these is going to have to encourage you to take a look in the mirror. And I certainly wish someone had told me this earlier, because a lot's changed in 10 years since I started practicing to now. Obviously, experience teaches you a lot. And back when I first started practicing, I wanted to believe that I was an expert. And I'll give you a quick example here. So once I got done with residency and I moved to Arizona, started practicing out there. The first real job, the big boy job outside of residency. And working at a great clinic, outpatient orthopedics clinic, so I was seeing all types of orthopedic injuries, occasionally some athletes, but a lot of it was low back pain, knee replacements, things of that nature. And then what happened was a pain management physician started renting an office a few floors above us. And so I never wanted to get into pain management, and I really actually, in my head, kind of despised those patients, probably because of my own insecurities, but also because of all the biases and the stereotypes that you think of with a chronic pain patient. And at this point, I'm ashamed to kind of admit that. But when this happened, I was frustrated because we started getting these referrals from this physician, which was great for the business, but unfortunately, that population really challenged me. I didn't want to work in pain management, and it kind of felt like it was pushed upon me without I didn't have any say in it, right? And so as time went on, and I look back now, the best thing that could ever happen to me in my career was seeing these patients that I did not want to see, and these patients that would leave me high and dry, and these patients that had some yellow flags and mental health issues. And it really taught me to work with a very, very diverse patient population. And what it's helped me with now in the sports medicine world is I can take those experiences and I can apply them to our athletes here, because these athletes have chronic pain. These athletes are always something doesn't feel good. There's a lot of individuals now that are diagnosed with some sort of mental health condition. Anxiety, depression, bipolar, all is very, very prevalent. Maybe it's being overdiagnosed, or maybe it's being diagnosed the correct amount now because we have other ways to, or more improved ways to figure those mental health issues out. But that's why I wanted to add this chapter, is because that was a big mistake I made, was I took the wrong approach early on. So we move on. Here I come popping up again. You should actively try to confront your implicit biases, and that's something I had to really learn. If we continue on with chapter 3 here, if that's not what I want to treat, the APTA actually has some good information about this. In 2018, June 2018, PT in Motion magazine, they looked at this, and so I cut out an article or a paragraph there that states that human beings naturally like to think of themselves as non-judgmental and bias-free, and I certainly thought that early in my career. It's like, I don't really care, I just don't want to treat you. And first, no PT or PTA, indeed no one at all, is free of bias. And then second is that everyone treating everyone the same isn't desirable because that approach doesn't account for the different experience and attitudes that each patient brings to PT. And that's one of the great things about this profession is everybody you meet, you can learn something from, whether it's a patient or a physician or another PT or a front desk staff, et cetera, right? You should take the a mindset of being a servant of the individuals you meet and try to do things for them and treat them with respect. And that will come back, tenfold on you if you do that. But the existence of implicit biases and stereotypes in healthcare professionals and influence on quality care has been studied. And so there's this study here, you can see the reference at the very bottom of that slide, Implicit Bias in Healthcare Professionals, a Systematic Review. And some of the things that we may not understand, and maybe that's the wrong term, but we may not be aware of or we may have to dive a layer deeper to really bring these out and analyze and self-reflect are issues here in red. And some are obviously more common, more mainstream than others, right? Race and ethnicity, obviously you could have bias or prejudice, right? Gender, of course, stereotypes and things like that. Socioeconomic status, age, mental illness, weight, AIDS or other diseases, brain-injured patients, and intravenous drug users, disability, social circumstances. And my challenge to you is that all of these people, especially when we think about like IV drug users and things like that, all of these people have their own set of experiences that they bring to the table. And if you are judgmental and decide that you're not going to invest in them, then who will? And so we really need to change the way that we think about some of these things. So we move on now to chapter 4 is, wow, we have to fix your imbalances. You're jacked up. This is all types, we're going to talk about nociceptive language and how that can hinder your patient's progress. Not only that, but what's harder is reversing someone's opinion of their own physical condition. And so, how many times have we seen this where, you have a patient that goes in and they're like, I'm great, I can take over the world, but I'm just having a little back pain. And then they come back to you and they say, my doctor told me I have the spine of an 80-year-old, something like that. Or my knees are jacked up, or I've got the biggest meniscus tear that doctor's ever seen. They don't even know how they're going to fix it yet. This type of language, and PTs are actually really bad at this too, is trying to find something that's wrong. Something that may be a normal variation or normal adaptation to the demands of your physical condition or your environment. And unfortunately, we try to make it seem like something is really off with individuals. And so some examples of that, well, first, let's get into this study out of JOSPT. It's called Sticks and Stones, the Impact of Language in Musculoskeletal Rehabilitation. And so one of the great charts in this, you should read it. It's an opinion piece, but it's a great one, and it's been shared a lot. But one of the tables here I've just copied and pasted over is words to avoid and alternatives when you're chatting with patients. So let's go through them. So if you're chatting with a patient, you say that, the doctor's note says that you have chronic degenerative changes in your knees. The patient looks at you and goes, what? Degenerative? And what you should say, though, is something like, there's normal age changes in your knees, right? Because multiple studies have come out now that look at asymptomatic individuals, and their imaging looks similar to symptomatic individuals in terms of arthritis or joint space narrowing and things like that. And so for us to just throw out there that, we could be more tactful, essentially, in how we present it. I think the medical lingo is degenerative changes, obviously, degenerative joint disease and things like that, those sorts of diagnosis, but we don't have to share that with the patient because I think that term degenerative is nociceptive. And we want to be careful with patients may not understand the difference between a positive test and a negative test. They say positive, that means good, right? Negative means bad. So you go, yeah, your MRI was negative. You're like, what? No, I mean, everything appears normal. It's negative for anything bad. It's like, oh, that's like a double negative or something. So you just need to be careful there, right? Instability. That's just a term that someone might need more strength or more control. Wear or tear. That's normal age-related changes again. Instead of using the word neurological, why don't you use the term nervous system? Because neurological implies that there might be some sort of serious medical condition, where they may just have carpal tunnel, something like that. Telling a patient "don't worry" is in and of itself an anxiety-provoking term. It's actually everything will be okay. That's much better. Don't worry, don't worry. How many of you are married or have pretty deep relationships with a significant other? Doesn't it make you mad when they say "don't worry"? It certainly does in my household, and I've learned from that in that aspect too. So the term "bone on bone," right? Why don't you just say narrowing or tightness? And you can move down the list here. And so just know that when you talk to a patient, they actually take in a lot more than you think they do. They really, they'll go home to the dinner table that night, and their spouse or their family members will say, "Well, hey, how'd your PT visit go?" And it's like, "Well, my therapist thinks I have kyphosis in my spine." It's like, what? It's like, what? Well, what is that? Like, you did a poor job then. If that's what they took from the setting, the session with you, is that you mentioned a big scary word like kyphosis, something they've never heard before. That sounds like it's some sort of condition. Are you doing that because you want to sound smart, or are you doing that because you tried to lines are getting crossed, or I should say communication signals are getting crossed. So what I always say is that you should try to talk to your patients like you're talking to a family member. You wouldn't, your weird or crazy uncle that comes and sees you at Thanksgiving once a year. Yeah, hey Russ, something's wrong with my back. Can you check it out? You're not going to go, well, you have scoliosis and kyphosis, and your thoracic spine's really jacked up, and et cetera, right? You'd probably say, hey, you need to start moving a little more. You should probably think about working out, getting better sleep. Here's some stretches or exercises I can give you. I think these will help. If there's anything that's aggravating, why don't you discontinue that? And you can really change the way that you're perceived, or that a person thinks about their own condition. So again, here's some photos that just look at this. So, degenerative changes are, you think these athletes in the bottom right picture, if we scan their joints, their joints would look like they're that old. I think they probably would, but I'd much rather have an athlete like this with poor joint space or tissue, quote unquote, degeneration than maybe an individual who's not as active. And so I just want to challenge you guys on that. So again, we have to fix your imbalances, and this is all about nociceptive language. And then we get things like this, where this is the 5. I mean, look at this. It's like the 5 red flags of pronation. Last time I checked, pronation is a normal thing that happens with walking. I mean, it's part of the gait cycle. I mean, you go into some pronation. We also know that there's how many billions of people on Earth? 7 billion, something like that. How many, if you had them stand statically, would have navicular drop? Probably 4 billion of them. It's just crazy, So, these types of pictures that people see, and this is obviously a foot orthotic company that's trying to sell some orthotics or heel lifts or something. As the arch drops, the knee rotates in. Look at your knee now; it's really out of alignment. Your pelvis is now tilted, and now your shoulder drops. It's like, man, you are jacked up, all because of your pronation. And so I've heard, over my career, I've heard coworkers, therapists, and especially people online talking about stuff like this. And it's just certainly to make yourself feel better and not the patient. I think in some extreme cases, right, if we talk about navicular drop or someone who's extremely hypermobile or something like that, sure, some inserts can help. Alignment is a term I hate. I think anytime you're trying to get into talking about alignment, then you probably have no idea how the human body actually moves dynamically through the environment. And so we shouldn't care terribly much about static positioning. And so some of those things during your exam, I want to challenge you on. making sure that you're not over-diagnosing and fear-mongering with patients. So here's another thing. It's like, I think this is from a chiropractic office, but you could say this is certainly from a PT office too. I mean, we do a poor job with this as well. So, your neck's misaligned, and so now your brain stem is compressed, and you're getting distorted brain messages. Like, what the hell? Like, were you in a car accident and you have like, a spinal cord injury, or do you have TBI? No. Well, do you think like a little bit of an tilt of your head on an X-ray means that you have distorted brain messages? Like, can we do better than this? I mean, seriously. And you can just look down the list there from the head all the way down to the ankle. So this is another one, and this probably is something that you guys have seen in your textbooks. I know I certainly did. And back in PT school, I was like, whoa, there's people that look like this? I've never seen people like this before. And the reason I never saw people that were like this before is because this is a gross exaggeration. And so, if you ever tell someone that, for instance, that the forward head thing, I mean, come on, guys, like the lordosis, like it's obvious that this individual is doing this for this picture, but we simply think that, these static postures have something to do with pain because we want to diagnose them with something. I mean, they're in front of us and they're having some sort of discomfort, so it must be their positioning. But I challenge you that all of these are a variation of normal. And so I would argue that this person with the good posture probably looks the most rigid and stiff of all of them, and hope that he can get in and out of that position rather than just staying straight as a board. So who's to say that's the best posture for you? I mean, some people might, you think this posturing would be good for a gymnast? To some extent, I'd say yes. And so you got to think about the demands of the sport. But can we stop with this crap? So I want you guys to really internalize that. Does anybody know who this individual is on the left? Someone with pretty bad scoliosis. And if you watch sports in the Olympics, you probably can recognize this individual even from their back. But it's the fastest man that's ever lived. He has bad scoliosis. You can look it up online. And maybe his scoliosis actually allows him to have better power output in some respect. I mean, he's extremely long. You slow down his starting blocks. He gets off the block. If you look at him from the front as he pushes off the blocks, the way that he moves is kind of like a snake, right? And is that because he has some lateral tilt in his spine? Maybe. Certainly, he's faster than anybody that's ever lived. So, he has scoliosis. Let's get over it. Look at this jacked up foot, right? Or that's what you might say if you saw somebody's foot like this. Dude, you got hallux valgus, hallux rigidus. What's going on with your fifth toe? This is crazy. Like, we got to fix your foot posture. We need to give you some short foot drills to do foot yoga. Let's go. And anybody thinking in their head who this might be? It's like debated as the greatest basketball player that's ever lived. So look, these are variations of normal human anatomy, right, in extremely athletic individuals. What about this picture? Look at this navicular drop. Geez, that's pes planus. Yeah, sir, you have pes planus, and you have an issue there. So we need to take care of that. Well, this is Kevin Durant, really excellent basketball player. Some would debate that he's better than LeBron James. Now, what you might say is that, well, Russ, Kevin Durant suffered an Achilles injury, and it's probably because he had a flat foot. Well, my argument is that he has such long limbs. He's 7 feet tall. So if you watch the video of him tearing his Achilles, he's going to hyper dorsiflexion moment, something that he's done likely a million times, where he drops back to plant his foot to go forward. And who knows why in that instance, that's what the straw that broke the camel's back. But he certainly practiced that movement, where his Achilles tore thousands and thousands of times. So my argument would be, well, what was his sleep like? What was his recovery process like? What was the moment that he was in? If I remember right, it was the NBA Finals, extremely highly stressful situation. Was he pushing his bodies to the extreme limits of his physical capacity? The answer is yes. And so maybe those variables are more important than static posture. So most aches and pains are not due to postural imbalances. They're most likely due to poor loading, spikes in workload, too much volume, and you guys know all of this. Not listening to warning signs. Are you having pain in your Achilles for the 2 weeks leading up to that game, and you just push through it because you have to, because it's extremely high pressure situation. Your team needs you. Those are probably the things that actually are leading to most people's injuries. Just one more comment here on thoracic kyphosis. There's a baseball player, Hunter Pence. He's known to have this. It's Schurman's kyphosis is a diagnosis that you see. Someone with a they get diagnosed with kyphosis. I mean, literally, an increased curvature in the thoracic spine. This guy is a perennial all-star and really great player. And I just got done treating a pitcher, professional pitcher that had kyphosis as well. So this is a fielding player, and then the example of a pitcher has this as well. And it's just you just got to be careful what you say, because even athletes, they're normal people. If you tell them something's wrong with them, they're going to take that message to heart. Here's Suni Lee, someone we've had the pleasure of working with at Training House. And would you say that she's hypermobile? It's like, hey, Suni, you're hypermobile. Yeah, well, that's the demands of her sport. What about this guy? Your shoulder range of motion is really excessive. Well, yeah, good. How about this individual? Sumo wrestler. Look how flexible he is. Would you say that that's a detriment to his sport? I mean, you want to be strong and stiff, but look how mobile he is. That's great. How about these individuals? These are all Olympians, all in different sports. The human body's amazing. Look at how different all of these people look, and how they still are at the peak of their sports. Would you say that guy in the middle with the hockey, would you say that he's got like a right shoulder drop, and he's, let's look at his foot. Oh, his feet are too high of arches. And, I mean, if you really think about it and criticize yourself, some of that stuff's just ridiculous. And what are you going to tell these individuals that you might have the pleasure of working with? And maybe they wouldn't be Paralympic caliber, but you certainly work in your career with amputees, spinal cord injuries, things like that. So are you going to tell them that they have a lot of imbalances? I mean, you go and tell the wrong amputee that they're imbalanced, they're going to keep that with them for the next 20 years. My therapist said I'm really out of balance. Well, it's like, yeah, you're out of balance. You don't have a lower leg. Like, your expectation now should be to feel good and to get as strong as you can, as flexible as you can. You're never gonna, unfortunately, you probably won't have the perception of feeling 100% balanced, but what you can be is really strong and really fit, and this is not going to deter you from those goals. So again, maybe what makes someone different is what makes them great, and use that to empower them, not to break them down. So very good. We're done with part one. Those are the big mistakes. So how do you hit your target? So the first thing is the KISS principle. You got to keep it simple, stupid. Keep it simple. When you're describing something to a patient, keep it as simple and as concise as you can. They really will take what you say to heart. If you ramble on and on and on and on, they're going to find little key phrases or words in your discussion with them that they pull out, and that's what they hold on to. And this is something that will get better. You'll get better at with time and with patient experience, clinical experience. This also applies to your coworkers one day. If you're sharing a patient, they're going to want to know, in the last session with you, how did things go? And so keep it simple, give them the most basic things, the big hitters in terms of continuum of care. And then the last thing with this is this should apply to your documentation as well. Documentation, you want that to be, at least from my experience and what I do, is I document by exclusion only. So it's like I'm going to exclude everything that that doesn't need to be in my documentation. So, if someone comes to you and you're like, "Well, tell me how's your knee been doing?" "Oh, It was last Sunday, and I got up really early that morning, and I went for a jog, and the weather was great. It was a little chilly, but it was not. And I saw Joe, my neighbor. I said hey to him for a couple minutes, and so this story goes on and on and on. And what you just need to know is like, yeah, well, how's your knee? Well, yeah, it's about the same. It's like, don't document that they talk to their neighbor, right? That you're going to be spending your entire life documenting if you do it that way. So really, I want you to criticize and analyze the way you document and see if you can become more efficient, because that's a mistake I made early on as well. Owning your ego. So what is ego? Ego is well, there's probably some psychology individuals in here, and so my understanding of your ego is it's like it's your alternate self. It's always trying to just be all, it's your unconscious that always wants you to be selfish for yourself, right? And so that doesn't mean if someone gets in your way, who cares? It's all about me. And so you have to be able to own your ego and essentially kill your ego. So I like this quote in the middle is, ego is the only requirement to destroy any relationship. So be a bigger person, skip the E and let it go. And ego is the enemy. If someone you're communicating with thinks that you have a big ego or you don't care about them at all, it's like, how many times have you guys been on a date or know someone's been on a date and you go, well, how'd the date go? And they go, well, they only talked about themselves. They didn't ask me any questions. So I don't know. I didn't really feel like there was a connection there. And so think about yourself with a patient. It's like, did you talk or did your patient talk more? Do you know how to treat their diagnosis? Were you honest with them, or did you say, yeah, I've seen this before, and we're gonna do this. And meanwhile you're going, oh, I've never seen this before. This really kind of intimidates me, but you let your ego get in the way. So Jocko Willink has a great book, and I'll tell you about it later, but his quote here is, once people stop making excuses and stop blaming others and take ownership of everything in their lives, they are compelled to take action to solve their problems. And so this is just a common thread here in what we've been talking about. So the next chapter here is build the base. What are your career goals? How do you get there? This is all about hitting your target, right? So do you want to do any postdoctorate work? Residency, fellowship? Where do you want to be in 3 years, 5 years, 10 years? How do you get there? Networking is huge. Why don't you look at your local area? Can you network with any individuals there? You guys are Minnesota APTA student conclave, student SIG members. I gave you my email earlier. Let's see how many of you guys email me about things, right? Are you going to take advantage of this situation? Regional, national, are you going to conferences? Are you sitting in the back of the conference hall, or are you going up after the conference ends and talking to some of the presenters because you found something interesting? Or are you just leaving going, oh, that was interesting, that was kind of cool. I wish I knew more about it, but you don't take the initiative to talk to anybody that's an expert in the field. And then the cool thing now is the virtual and Zoom stuff. So I've gone to 2 conferences in the last year virtually, right? One was in Alabama and one was in California. It's like I didn't have to get off my out of my chair at my desk. And afterwards, I sent some emails out to some people, and guess what? We've been in communication. So what are you doing to network? Build your base. You never know where your career might take you if you have the right relationships. So a strong foundation will allow for career flexibility and balance. So I certainly will tell you this. I never thought I was going to end up in Minnesota. And the great thing is that through residency and all those things, the opportunity arose, and my wife and I made the decision to move up here to be closer to family and for this opportunity. But if I never networked, I don't think I would have had the success I did in finding a job across the country. So I mentioned this earlier, but a term I've coined, relationships. It's a mixture of relationships and shaping your environment, shaping your future. So how do you perform a relationship? Well, you need to, 1, take a chance. Your professors, and I've heard this from some some students in the past that, and they're right, by the way, in some regard, is my professor told us not to, cold email anyone because, don't want to seem like a desperate student. And I can tell you, if you're the weird individual who continues to email and doesn't take no for an answer and, et cetera, yeah, it's like that gets annoying. But if you're a student who, we can tell is very driven and humble and wants to make a difference and wants to learn and ask good questions, then yeah, reach out to someone. Take a chance. That's what that's all about. Take a chance and put yourself out there. If it doesn't work out, move on. The next thing is if you're given a chance, be humble, right? Don't go into a situation thinking you know more than the person you're trying to shadow or you're trying to learn from. Refine the relationship. That's going to be time. Time's going to help that. That's about doing the right thing, showing up on time, taking ownership if you make a mistake, right? People love and realize that. You should be able to do things without being told. So let's say you do get the opportunity to shadow somewhere. Why don't you try to clean that table off, as that patient just left from, one of the coworkers or the person you're shadowing. And you see a piece of trash on the floor, or you're going to walk by it, you're going to pick it up, put it in the trash, right? Those little things people notice. Volunteering your time, that's probably a big one, right? If you're working with someone and they go, hey, we need you, would you be interested? We really would need you to be out. Well, no, I was planning on sitting on my couch and watching The Bachelorette that night. It's like, well, did you just advance your career, or did you just took some you time? And don't get this wrong, you time is important, but where is that? It has to align with your goals, right? And then let's say that situation comes up where they want you to volunteer, but you actually think someone else is better fit for that. You should be humble enough and check your ego enough to go, actually, I think, my classmate, Tony or whoever is a better fit for that. They're really interested in soccer, and you're asking me if I want to come cover a soccer game with you. It's like, well, Tony's been telling me in class that he wants to be a soccer PT one day. It's like, could you take that advantage and build that relationship with Tony? Yes, you could. And then finally is just ask for help. So that's how you build relationships. That's what I've done, is all these things here. And in this slide, I really tried to critically think about things that helped me get to where I am in my career. And certainly I've certainly made mistakes essentially in all of these steps as well. And to the point where I've burned some bridges, by the way. So don't do that. So part 3, conclusion. Hopefully this is you, this background picture. You're reaching the summit of your career. So doing the right thing. Consistency is what transforms average into excellence. I like to think of this term here, micro-benevolence. So we know benevolence means good, doing good. But what are you doing on the micro level? On the day-to-day level, are you doing the very small, minute things good? Are you doing them with a good purpose, good ethics? For instance, I talked about the trash on the floor. Are you going to pick that up? If you're a 10-year vet PT, or are you going to leave that there? That's the tech's job. Tech's got that. No, this is a team. Like, you're not better than the tech. You're the same as the tech. You just went to school. That's all. The only difference. They're still a person. You shouldn't have to pass that grunt work onto them. Things like that. Are you saying hi to your front desk? Do you once in a while bring in donuts for the staff? Right. Those little things go a long way. You really need to realize, how happy are you when you're at a clinic and someone brings in donuts? You're like jacked up about it. It's like, let's go. When's the last time you did something like that? If it takes you less than a minute, why haven't you done it yet? It's another thing, Not only is you talk about the trash on the floor, I think that's a really great example, so I keep coming back to it. But it's like you're walking into the clinic for your 8 a.m. patient, and someone else has a patient at 7:45, and you're kind of getting there at the same time. Are you going to walk fast past that person on crutches and like go into the building, or are you going to go to the door and hold the door open for them? It's like, that took a minute out of your time. It's like, that's the right thing to do. Little micro benevolent situations like that. And then be dependable. If you say you're going to do something, make sure you do it. For me, early in my career, that was something that was really hard to do. I'd say, yeah, I got that, and then I'd forget about it, right? And it's like, well, Russ, we can't trust Russ. He said he was going to do that, and he never followed through on it. So what I had to start doing, literally, is start back. This was 8 or 9 years ago. Is carry a little notepad with me, which is why I put the notepad on the side here, and I would write down things. I mean, that's how I had to try to remember, and I'd look back at the end of the day and say, what do I need to get accomplished? And so now I have just my my iPhone, the app on my iPhone has notes, right? And so I'll just jot it down there. But you should create checklists, and that helps you be dependable. And you'd be surprised that when someone realizes that you're a person of your word and you do what you say you're going to do, that's a rare thing these days. And so make sure that you're really thinking about and criticizing yourself on how dependable other people perceive you to be. And then just try to be consistently consistent. There's going to be days, highs and lows. You have good days, bad days, but overall the trend should be consistently doing the right thing. So passing it on. You don't want to try to find mentors. These may come in different shapes and sizes, right? It's a two-way street. It could be a mentor that's in the physical therapy profession. It could be a mentor that's in, just someone in your life that you respect that may be in a different profession. When I say it's a two-way street, it means you should try to give them advice and things as well, or tell them where they are falling short if you have this relationship with them. So if someone takes you under their wing, you know it, right? It's like someone who texts you out of the blue, hey, how are things going? Are you doing all right? Like, make sure you text them back once in a while. When you're a PT and you've practiced a few years, or whenever you may feel comfortable, take on some students, take a chance on them. Some of the best relationships I have in the physical therapy world are students that have done a clinical rotation with me. And it's really fun and cool to see how an individual grows and how you grow from your experience with them. And then last thing I just tell you is read. Read as many books as you can. So, life gets busy sometimes. There's some seasons of life where you can't read. Like right now, maybe some of you are studying for your board exam. Like, probably shouldn't be reading a book right now, unless it's relaxing and you like to do it as a way to decompress. But, maybe the last thing you want to do is read when you're looking at a textbook all day anyway. So, but that's my advice to you, is when life settles down a little bit, make sure you read, because those times where life is not as busy are times where you can really learn a lot. And so 3 books that have really shaped my practice, and I try to get every student to read these as they come in and do a clinical with me, is Atomic Habits by James Clear. It's a really great book on how to break bad habits and how do you set yourself up for success with creating new habits. The other one is Extreme Ownership by Jocko Willink. And so he's a former Navy SEAL that he's written this book on how you can improve your integrity, essentially. And then the last book is Robert Greene's Mastery. And so this is where the old stat of it takes 10,000 hours to be a master at something comes from this book, right? And so they dive into the steps and tools and things you need to become an expert in your desired field. So these are 3 books that I would definitely recommend, and I recommend often. So just want to say to you all, thank you for attending. I would love to answer some questions now if you have it. If not, hopefully my presentation was well enough that you guys maybe don't have a lot of questions, and maybe it just takes you making mistakes yourself. So, I think I lied about this being short. It ended up being an hour. I thought it was going to be about 45 minutes. So, again, you can contact me on these different service lines. So, thank you guys very much.